Welcome to TeleShadowing. We are live on YouTube. As always, feel free to ask questions in the chat box as we go along, and your questions will be addressed. We're actually going to be continuing our Nephrology Month and Pathway to Med Ed series. So we're actually going to be learning today about two specific diseases, specifically acute kidney injury, also known as, sometimes referred to as acute renal failure, and also UTIs or urinary tract infections. You may know of someone, or you may have had this UTI. So I felt that this might be very interesting to learn about just the basics before you all start medical school someday. So to kick things off, I just want to review from last week that kidneys, of course, are our two bean-shaped organs that are located on either side of our spine, right below our rib cage. And they play a very, very important role in filtering our blood, removing our waste products, and also balancing fluids and electrolytes in our bodies. And I'll walk us through our basically how they perform these functions when it comes down to things that go wrong. So I want you to all imagine, basically, remember when we learned anatomy that there is a blood supply to the kidney. The kidney then filters the blood, remember the glomerulus and the loop of Henle and all that, the nephron, which is the functional unit of the kidney. And then there are the ureters and then the bladder, right? So again, just remember this process of blood vessel, kidney, then ureter. That'll be very important understanding acute kidney injury, at least as at the basic level. So AKIs, or acute kidney injuries, they involve a sudden decrease in renal function, which typically develops over days. So there's something called azotemia, and we'll learn about azotemia. Basically, azotemia is characterized by elevated BUN, or blood urea nitrogen. We're going to learn about that as well, and creatinine, which is a key indicator of AKI and often presents with oliguria. And oliguria is just a fancy word for reduced urine output or urinating less. And AKIs can basically be classified based on their etiology. Etiology is just a word that just means the root cause. So there are three different types. As you can see in the chart here from Ambos, there's something called pre-renal azotemia. That's caused by reduced blood flow to the kidneys. Then there's intrarenal azotemia, which results from direct kidney damage, like acute tubular necrosis. And then there is the third one, post-renal azotemia, as you can see in the green down here. That's usually due to obstruction of urine flow, like a stone, downstream of the kidneys, right? So remember the three. There's the blood vessel, kidney itself, and then the ureter, and then the bladder right here. So we'll learn a little bit more about these kidney function tests I mentioned, and just keep this in mind at the back of your head, because we will be revisiting these three: pre-renal, intrarenal, and also post-renal azotemias in the next few slides. So before diving into the AKIs, I just gave you just a general overview. It's really important to understand the basic kidney function tests that help us evaluate like how well the kidneys are working, and to identify azotemia, which is a hallmark of acute kidney injury. So azotemia is basically a condition where there are too many nitrogenous waste products in the blood, usually due to the kidney's inability to filter them out. So again, this is an example of the kidneys where all the filtration that it's usually supposed to be doing in a healthy patient doesn't do it. So it's a common feature of chronic and also acute kidney injury. And basically, azotemia occurs when the body breaks down protein from food and drinks, which creates waste products in the liver that travel to the kidneys. And healthy kidneys are able to filter these waste products out of the blood and remove them from the body through urine. And when the kidneys can't filter waste products properly, they build up in the blood. So azotemia can be caused by a number of factors, like any condition that might reduce blood flow to the kidneys, like if there's a burn, if there's any dehydration, also heart failure can cause it. Also injury to the kidneys or the glomeruli, the tubules, interstitium, or the small vessels. There could also be like an obstruction in the collecting system, like I showed you before, a kidney stone. So those are just a couple of causes of azotemia specifically. A few symptoms of azotemia, they include like itching, nausea, vomiting, damage to the brain, and also weakness or numbness in the hands and feet. And so these are some very vague general symptoms that you'll need to be able to rule out in your differential diagnosis to truly address the root cause and make sure that your patient feels better. So Azotemia, just to get to the topic of this slide here, it can basically be diagnosed with blood tests and a urinalysis, including a blood urea nitrogen or BUN test, a creatinine test, and also a 24-hour urine collection test. So there are also other diagnostic techniques like ultrasound, X-ray imaging, also catheter insertion, but for now we're going to focus on what specifically these kidney function tests tell us. So before we get into AKIs, I did not mention this in the last session, but this is very important. Glomerular filtration rate, or GFR, it's one of the most important measures of kidney function. So I'm going to break it down into simpler terms because this is how I remember it. So again, GFR stands for glomerular filtration rate, and that's basically the rate at which the kidneys filter blood. And it basically represents how much blood is filtered by the glomeruli, which are known as, of course, the filtering unit of the kidney per minute. And it's typically measured in millimeters per minute, like ml/min, if you've ever looked at some lab values. So GFR is very important because it's that primary indicator of kidney function, and it basically provides an estimate of how well the kidneys are filtering waste, excess fluid, and other toxins from the blood. So if there is declining GFR, that's usually a sign of kidney disease or damage. And like GFR is usually measured directly. It can be complex, but it typically involves like injecting substances like insulin, which is a marker filtered by the kidneys, and tracking its clearance. But this method, like this direct measurement method to find the GFR, is rarely used in clinical practice because it's very, very time consuming. So instead, in clinical settings, we rely on something called the estimated GFR or the eGFR. You might have seen it in lab values. Like there's like a small e, lowercase e, and a capital GFR. And that's calculated from the serum creatinine level, which is more practical and more efficient. So the factors that are used in eGFR calculations include like age, gender, body size, and the main input is serum creatinine level, because like as you age, the GFR naturally decreases. Gender is important because biological males often have higher GFR due to the greater muscle mass, so that can sort of throw off calculations. And also body size, like muscle, because muscle mass affects creatinine production. We'll learn that next slide. And also very recently, ethnicity has been a topic of discussion because there have been differences in reported GFR values for African Americans and non-African Americans in GFR, but there have been many pushes for these adjustments to not really be clinically valuable. So if you're interested in learning more about that and GFR and more like social determinants of health, please, research it, look it up. It's a very interesting debate that's going on in more hospitals. In an effort to promote health equity, more and more hospitals are pushing for more GFR values that do not really take ethnicity in mind because recent studies have shown that it doesn't really change the GFR. In fact, it might be hurting patients who are African American, who are using GFR values. And so basically, just in summary, it's just really bad for people who are minorities here in the States. So it's very important to just like look at GFR, and if you are at a hospital that still uses like ethnic based GFR values, to just keep that at the back of your head and just be more cognizant for patients who come from minority backgrounds. So, getting back to normal GFR values, for healthy adults, a normal GFR is usually about like 90 to 120 milliliters per minute. GFR can, of course, vary based on age, sex, and body size. So in young adults, the GFR tends to be a little bit higher. But in older adults, the GFR gradually declines as a part of normal aging, which typically drops about like 1 milliliter per minute per year after the age of 40. GFR is usually used for like kidney disease staging. So there's another disease called chronic kidney disease, or CKD. It's classified based on GFR levels. Like if you have stage 1 CKD, stage 1 chronic kidney disease, you have a GFR greater than or equal to 90, which is normal or increased GFR with kidney damage. Stage 2 CKD would be a GFR between 60 to 89, which is a mild decrease. Stage 3 is GFR 30 to 59, which is a moderate decrease, and so forth. So like stage 4 and stage 5, CKD is much worse. Like stage 4 and stage 5 considered more of an advanced stage chronic kidney disease. Patients will usually be on dialysis by then, and or if a patient is in kidney failure in stage 5 chronic kidney disease, they'd have a GFR of less than 15. So that would be considered kidney failure. Usually patients like that may consider kidney transplant. So GFRs in acute kidney injury or AKI specifically, the GFR actually drops suddenly within days, which indicate like a rapid decline in kidney function. So a low GFR in AKI usually is accompanied by azotemia, which is elevated BUN and creatinine, and oliguria, like we talked about before, which is reduced urine output. And that basically reflects the kidney's inability to clear waste products efficiently. So again, just to summarize, like if you have a higher GFR, that means you have better kidney function, meaning that the kidneys are effectively filtering waste like they should be. If there's a lower GFR or extremely low GFR, like less than 15, that's indicative of a like kidney failure or very reduced kidney function, which suggests like potential kidney disease or acute injury that you'd want to investigate further if you see that on a patient's labs. So, of course, monitoring GFR really helps you assess the severity and progression of kidney conditions, whether they're acute or chronic. So, understanding GFR specifically as a very important and optimal lab value will help you guide your treatment decisions when you become a clinician. So now we'll talk about kidney serum creatinine. And I'll talk about it very briefly. So creatinine is basically a waste product of muscle metabolism that's filtered out by the kidneys. And this is important because when the kidneys are functioning well, they clear creatinine from the blood efficiently. And if the creatinine level like rises, then that kind of suggests that the kidneys aren't filtering blood effectively. A normal range is generally around 0.6 to 1.2 milligrams per deciliter in adults, but it can vary based on muscle mass, like I said before. Now there's also blood urea nitrogen, like I talked about before, BUN, not bun, BUN. I know a lot of people sometimes say, oh, the bun. No, it's BUN. So here, what BUN is where basically, if you remember from metabolism or biochemistry classes, that urea is produced when the liver breaks down protein, and that's basically another waste product that's filtered out by the kidneys. But it's important because like creatinine, an elevated BUN level would also indicate reduced kidney function because BUN should be filtered out. It shouldn't be in the blood. So there's more of it in the blood that probably means that your kidneys are declining in function. So BUN tends to rise much more significantly when there's dehydration or when the kidneys are struggling to clear waste. And a normal range would be anywhere around 7 to 20 milligrams per deciliter. And then there's something called a BUN to creatinine ratio. So the ratio of blood urea nitrogen, BUN to creatinine, is basically this very key indicator of kidney health. There is a normal ratio between 10 to 1 and 20 to 1, but the range can also vary based on the lab company. A ratio that's outside of this range basically could indicate a kidney problem or other health issues, like a high ratio, like above 20 to 1, could indicate dehydration, kidney disease, or other health issues. And it could also be caused by conditions that reduce blood flow to the kidneys, such as CHF or congestive heart failure, or by increased protein in the diet or from a bleed. A ratio of 50 to 1 or higher is dangerously high, and that would require like immediate medical attention. That's considered a medical emergency. A low ratio, like a ratio below normal, like below the normal 10 to 1 to 20 to 1 ratio, could indicate liver disease or malnutrition. And a low ratio in cases of something called acute interstitial nephritis or AIN can also emphasize this renal impact that this low ratio would have. There are other factors that can affect BUN levels. Those include aging, steroid use, and also burn injuries. But comparing basically the BUN to creatinine in this ratio can help differentiate the cause of the AKI. That's why this is important because remember, I said before, it could be caused by the blood vessel, the kidney, or the ureter, right? So you want to know, is this pre-renal? Is it Post-renal is an intrarenal azotemia. So a high BUN ratio, like greater than 20:1, often would indicate a pre-renal azotemia, which is due to decreased blood flow to the kidneys. And a normal or low BUN ratio can indicate intrarenal or post-renal causes where there's direct damage to the kidney or obstruction of urine flow. There's also something called fraction excretion of sodium, or FENA, and that's basically a measure of the percentage of sodium that's excreted in the urine compared to what's filtered by the kidneys, and it helps to differentiate the causes of AKI. So if the FENA is less than 1%, it indicates pre-renal causes, because the kidneys are trying to retain sodium to maintain their blood volume. And a FENA of greater than 2% would suggest intrarenal causes, like something called acute tubular necrosis. You don't have to worry about that for now, but just have it in your subconscious mind, acute tubular necrosis. That's basically where the kidneys lose the ability to reabsorb sodium effectively. And I'm going over these very briefly, just so that we have just a basic vocabulary, so that you're not intimidated by them when you hear about them in med school, or when you're shadowing like a nephrologist's office, or really any internal medicine doctor who is ordering labs. There's also something called urine osmolality, and this is useful because it measures how concentrated the urine is. In AKI, if there is a high osmolality, like greater than 500, that often indicates pre-renal causes, like basically telling you that the kidneys are concentrating urine. And if there's a low osmolality, less than 300, that indicates intrarenal causes like acute tubular necrosis, like I said before, where basically it's saying that the kidneys are the culprit and they can't concentrate urine as effectively. So here I'm actually going to describe pre-renal, intrarenal, and also post-renal azotemia. And I'm actually going to try drawing today really briefly. So let me get that, let me annotate. And maybe this will help us all remember and never forget. Let me clear all drawings. Okay, there we go. Okay, basically, let me actually color code this. So first we have, I'm going to draw a kidney, okay? This is just, here's, well, that's not a very good kidney, but get the idea. You know, maybe I can redraw this. Something like this. Okay, this is our kidney. I'm gonna write a K for kidney, okay? We also have a blood vessel, right? That, of course, feeds the kidney, right? This is really how I remember it, right? So this, I'll just call it blood vessel, or BV for short. BV for short. All right. And remember, the kidney is draining out into the ureter, right? So I'm just going to, I guess I'll draw it here. Oh, let me use a different color. Okay, here we go. The ureter, somewhere like that. It actually should be a bit thinner. Something like this, okay? And this is the ureter. I'll just write the letter U, okay, for ureter. So if there is a pre-renal disease, okay, if there's a pre-renal, so pre-renal, that basically means that there is decreased GFR. So let me write that down. Decreased GFR, and also decreased blood flow, okay? Because look, pre-renal is basically indicating that that there's an issue here in the blood vessel itself. So if I make an X right here, there's an issue here in the blood vessel. There's an issue in the blood vessel, then it would be a pre-renal azotemia, right? Due to decreased blood flow, like I wrote on the left hand here, right? That doesn't mean that there's anything wrong with the kidney or the ureter. There's nothing wrong there. There's only wrong with the blood flow. So basically, the prerenal azotemia is caused by reduced blood flow to the kidneys, which leads to decreased filtration at the glomerulus. And it's the most common form of AKI. It's often due to issues like dehydration, heart failure, or blood loss, basically where there isn't enough blood volume reaching the kidneys. So if like I can explain the mechanism a little bit more now that we had this like little like small rudimentary elementary drawing I drew here. So if there's low blood flow, there will be decreased GFR, okay? Now the body basically tries to compensate by increasing reabsorption of water and urea to maintain blood pressure and circulation, which leads to elevated BUN ratio, greater than 20 to 1. And because the tubular function is still intact, right? Because there's nothing wrong with the kidneys, it's only something wrong with the blood vessel. So since the tubular function is still intact, the urine becomes more concentrated, which shows a high osmolality, like I said before, so greater than 500 m-osm per kg, and sodium reabsorption is also high. So the FeNA would also be less than 1%. A few clinical clues, if you are reading like a question or you're seeing a patient or you're reading a case study, you would see oliguria or low or decreased urine output. And it's often reversible with fluid resuscitation to restore blood flow to the kidneys. So of course, like I said before, the key lab findings would be increased BUN and creatinine, also a high BUN ratio greater than 20 to 1, an FeNA less than 1%, and a urine osmolality greater than 500. So remember that basically there are compensatory mechanisms in the body beyond just in the smaller picture here. I want you to see the big picture, where basically if there's reduced blood flow to the kidney, that would lead to decreased filtration, but there's still intact reabsorption of sodium and water in the tubules because the kidneys are functioning fine. It's just the blood vessels that are affected. So that's just kind of what I'm trying to say. Like you want to be able to compensate for the reduced blood volume, and so the kind of kidneys are kind of sort of working overtime, which leads to the basically the concentrated urine. Now let's talk about post-renal azotemia. Okay, basically post-renal azotemia, let me get my colors here, would be affecting the ureters. Basically, if there's some kind of obstruction here, basically there's a blockage of outflow happening right here. So here, I'm just gonna call it number 2 here, post-renal azotemia, where there is blocked outflow. That would lead to actually an increased kidney back pressure and also a decreased GFR again, decreased GFR, which would actually lead to acute renal failure. So let me just try to move this so it's easier to see. Here we go, post-renal, right? If there's blocked outflow. Just to explain this a little bit more beyond the drawing, basically the post-renal azotemia is due to obstruction of urine flow downstream of the kidneys, right? Such as like in the ureters, the bladder, or the urethra. A few common causes include benign prostatic hyperplasia, BPH, or kidney stones or tumors. Basically, it initially causes increased pressure in the tubules because if there isn't, let me actually draw this out, it might make it easier. If there isn't the appropriate flow happening from the kidney to the ureter, that basically means that there is increased backflow back to the kidneys, right? It would be increased here because this is blocked. If this is blocked, that basically means that there is a backflow. That backflow increases the kidney back pressure. So I hope that made sense. And the mechanism of that, basically, when there's increased pressure in the tubules, because of that increased backflow, the tubules are in the kidney, there's increased backflow, increased kidney back pressure, that would impair the glomerular filtration. Remember the glomerulus, the functional unit of the nephron, and nephron is functional unit of the kidney. So that's the glomerulus will not be able to function appropriately with that increased pressure because that is not homeostatic, that is not physiologic, that is not normal for us. So an obstruction that leads to a back pressure in the kidney tubules that would maintain a high BUN ratio but intact tubular function. But if the obstruction persists, like if that kidney stone is not removed, then the tubular damage occurs, and that leads to decreased ability to reabsorb sodium and water. And in the early stages, urine concentration remains high, like the osmolality remains over 500, but with prolonged obstruction, the urine concentration decreases and the FPNA rises above 2%. So the clinical clues you'd use in this picture, if there's a patient with something like this happening, the patient would have symptoms depending on the site of obstruction, like they would have flank pain or lower abdominal pain. They'd also have difficulty urinating or changes in the urine flow. And recovery really depends on the prompt relief of obstruction. So, like I said before, the key lab findings would include like initially high B1 ratio, but then that would drop with persistent obstruction because there would be tubular damage, like the kidneys would get affected because of this. Remember, I talked about before, the blood flow doesn't really affect the kidneys, it just causes the kidneys to work over time if there is decreased blood flow, but if there is increased backflow because of the post-renal azotemia happening, or well, actually the post-renal azotemia is a result of the blocked outflow in the ureter. So as a result, if it's found early, then the FeNA would be less than 1%, the urine osmolality would be greater than 500, but if it's late, then the FeNA would be greater than 2%, and the urine osmolality less than 300. So remember, like, you don't have, I didn't put these numbers on the side for a reason. Like I don't, that's not the point of this lecture. Basically, what I want you to, the key takeaway point I want you to take away from this is basically our bodies are not static. They are, they're trying to compensate as much as they can. And remember that our kidney is like is literally a living organ, right? In a living system. So because it's in the system, it will try to compensate. And if it's not, then it will become more and more damaged over time, which is what could throw off the lab values. And it's actually very complicated. It's very hard for me to really understand it and grasp it really. So remember, it takes practice to remember all these things, and it doesn't just come, overnight. So it takes practice. So again, like I just wanted to highlight like how the reason, like if there is a blocked ureter for some reason, then it would increase tubular pressure eventually. And then the prolonged obstruction would eventually lead to tubular damage, would reduce the ability for the kidneys to concentrate urine. Now let's talk about intrarenal or intrinsic azotemia. So you might have already guessed it, that intrarenal is referring to the kidneys, right? Intrarenal, something happening in the kidney itself right here. So if there's something wrong in the kidney itself, then basically, let me just write that down for you all. Intrarenal, in the intra, right? And that's the intrarenal. Let me just move that here so it's easier to see. So if there is some kind of obstruction here, let me just try to illustrate that with maybe an X, sort of. That makes it hard to see, but I'll pick up the idea. So if there is an issue happening with the kidney here, some kind of malfunction or something like that, to that effect, the intrarenal AKI would basically involve direct damage to the kidney tissue, specifically usually like the tubules, the interstitium, or the glomeruli. And common causes are usually acute tubular necrosis, ATN, usually due to ischemia or nephrotoxic agents, or sometimes the nephrotoxic agent is just referring to like medications you might be taking that may be affecting the kidneys. A lot of heart medications do that sometimes. Another cause could be glomerulonephritis or interstitial nephritis. So in acute tubular necrosis or ATN, basically the necrotic tubular cells, they do something called slowing off, slow off, and they basically block the tubules, and that would lead to a reduced GFR. So again, because there's damage to the tubular cells, they will lose their ability to reabsorb sodium and water. Remember, that's what the loop of Henle does, and remember all the nephron and all that functionality from our anatomy lecture. That would result in a diluted urine and increased FeNA. So unlike prerenal and early postrenal azotemia, the intrarenal azotemia causes low BUN ratio, like less than 15 to 1, because of a loss of reabsorption capacity in damaged tubules. So the clinical cues that you would get in a case like this would be oliguria, reduced urine output, with brown granular casts in the urine. That's very specific to ATN, or acute tubular necrosis. It's often associated with ischemia, like prolonged low blood pressure or sepsis, or toxins like aminoglycosides or radiocontrast agents. So just to summarize the key lab findings, the BUN ratio is less than 15 to 1, or FENA is greater than 2%, and the urine osmolality is less than 300. There's also a presence of muddy brown casts. Muddy brown casts is basically like a step one buzzword, that would usually indicate that there is intrarenal azotemia, and usually referring to acute tubular necrosis. So I hope that made sense. And again, it's much easier to remember it if you kind of break it down the way I did here, with the kidney sort of, and the three, basically there's there's a blood vessel to the kidney, and the kidney is trying to drain into ureter and into the bladder. So that's sort of how I remember and organize the 1, 2, 3, and understanding that kidney back pressure really helped me understand and conceptualize this in my head. So we'll clear this all out. Now we'll move on to, again, the summary of basically what I just said. Prerenal AKI is due to decreased blood flow, and it has preserved tubular function and also high urine concentration. Post-renal AKI due to obstruction, initially presenting like prerenal AKI, but it leads to tubular damage if it's persistent. And then intrarenal AKI is usually due to direct kidney damage, with impaired reabsorption, a dilute urine, and typical findings such as granular casts or muddy brown casts. That's usually the buzzword there. So I hope that all made sense, even if just superficially. I hope that made sense. Just a general overview, broad understanding of it all. Learning things in a low stakes environment helps you retain it better in the future when it does become high stakes. That's called spiral learning. And I think we went over that as well during our adult theories of learning lecture, I think back in August of 2024. So if you're interested in learning more about spiral learning, feel free to refer to that. So now we're going to switch gears and talk a little bit about urinary tract infections, or UTIs. Let's go through UTIs. Basically, I just want to go over it in a structured way, starting from the basic principles and then moving on through the different types. So basically, UTIs, they refer to infections that can affect any part of the urinary system, which include the urethra, the bladder, or the kidneys. And the infection usually begins as a lower UTI in the urethra or the bladder, but it can ascend to the kidneys in more severe cases. And some common pathogens, like the majority of UTIs, are caused by bacteria. With E. coli or Escherichia coli, E. coli, it accounts for about 80% of cases. There are other pathogens that include Staphylococcus saprophyticus, Klebsiella pneumoniae, and also Proteus mirabilis. And UTIs tend to be more common in females or women due to the shorter length of the female urethra compared to males, and that provides bacteria with easier access to the bladder. Basically, that's why females tend to get it more often. I know that's something I was amazed to learn about the first time I learned it. And risk factors for UTIs include sexual activity, because that increases their risk of introducing bacteria into the urinary tract. Urinary stasis, there are conditions like benign prostatic hyperplasia, BPH, like I mentioned before. In men, or incomplete bladder emptying in both sexes, that can increase their risk. Another risk factor includes catheter use. Like indwelling catheters in hospitals provide a direct pathway for bacteria to enter the bladder. That would lead to catheter-associated UTIs, or CAUTIs. Excuse me. And the typical clinical presentation, the symptoms can really vary based on the part of the urinary tract involved, but the common signs would include dysuria, also called painful urination, frequency, like the need to urinate often, and also urgency, like a strong urge to urinate. So we'll talk about the different types. So that we talked, I mentioned before, there are three different types. There's cystitis, pyelonephritis, and also chronic pyelonephritis. So we'll talk about the first type of UTI called cystitis, or a bladder infection. And I want you to pay attention to this part because we're going to be having case studies and questions based on this one at the end. So cystitis. Cystitis is basically an infection of the bladder and is the most common form of UTI, usually presenting as a lower urinary tract infection. Symptoms, like I said before, include dysuria, like burning or pain during urination, increased frequency and urgency, like needing to urinate more frequently and with greater urgency than normal. There also tends to be suprapubic pain, like discomfort or pain in the lower abdomen just above the pubic bone. And there may also be systemic signs like fever, are usually absent. So, like, you don't usually have fever because the infection is localized to the bladder. Typical like laboratory findings in a urinalysis, you would find like cloudy urine. It's very common, and you would have a presence of white blood cells or WBCs, greater than 10 WBCs per high power field. And that's because remember, white blood cells are used to fight off infection, and so if there are greater WBCs, that probably means that there is an infection cooking inside your body, and so your immune system is sort of on high alert, and that's why you would see greater WBCs in your urine. You would also see a positive leukocyte esterase, which is basically an enzyme that's found in WBCs that indicate pyuria. Pyuria means pus in the urine. You would also have positive nitrates. That suggests the presence of bacteria capable of converting nitrates to nitrites, like E. coli, for example. And you would also have a urine culture done, and urine culture is really the gold standard for diagnosis, indicating significant bacterial growth if there's greater than 100,000 colony-forming units per milliliter. And so, really, urine cultures are how you're able to tell sensitivity to various antibiotics as a clinician, to be able to tell like if a patient is resistant to a specific antibiotic, you would not want to give them that antibiotic because it would do more harm than good. You would want to prescribe them antibiotic that they have not been exposed to before or that the patient would be sensitive towards. You would also use urine culture to identify what bacteria it is, because I mentioned before there are various different bacteria that can cause UTIs. And so these are the three bacteria: the E. coli, which is the most common cause, which is responsible for about 80% of cases. The Staphylococcus saprophyticus, it's especially common in young sexually active women, but still less frequent than E. coli. And then there's also Klebsiella pneumoniae and also Proteus mirabilis. They can also cause cystitis with Proteus that produces alkaline urine due to the urease activity it has. That results in a ammonia scent in the of the urine. So that's one way to tip you off. Like if you're reading a question and it says, "Oh, the patient reports an ammonia," like and or you say like during in a urinalysis report that there's a increased urease activity. That's how you know that this is Proteus and not Klebsiella pneumoniae. That's kind of how you're able to differentiate. That's why it's so important to have a strong grasp of microbiology. You would, just to really, I'm really going over very basics of the management. But basically, like you would use antibiotics, of course, because it's a bacterial infection. You would use for the first line treatment would often include drugs like nitrofurantoin or trimethoprim sulfamethoxazole. We usually call that TMP-SMX. You'd also want to increase hydration, like you'd increase fluid intake because that would help flush bacteria from the urinary tract. I also want like to kind of touch on prevention of UTIs. For example, like one way to prevent it would be postcoital urination, like basically urinating after sexual activity, because that would help clear any bacteria that were introduced during the sexual activity. And also practicing good personal hygiene, like wiping front to back to prevent a bacterial spread, or using like I know in many different cultures they use a um, I think in Europe it's called, let me get the right term. Get it really quick. Like in toilets that spray water based, oh yeah, a bidet. So like there are a lot of that using a bidet would also help beyond just like wiping. You would want to wipe front to back, of course, because you don't want to introduce bacteria from the other end to that side. So again, these are just preventative ways to prevent bacterial spread, and that's just staying clean and if you're able to. This is a screenshot taken from the first aid step one book that I tend to show. Basically, this summarizes what I just said. It talks about like the leading cause UTI, the second leading cause, third leading cause, and so forth. See, the Proteus mirabilis produces urease. And then you'd use like these diagnostic markers like leukocyte esterase or a nitrite test, because that would basically tell you that there is WBC activity. Remember, if there is active enzyme activity produced by a white blood cell, that probably is going to tip you off that there are high WBCs. They might not tell you immediately like, oh, there is a high WBC count. They might just say that there is leukocyte esterase activity, right? This is just sort of a two-step way to kind of tell you that there is an infection without really telling that to you. So that's sort of how these questions tend to be phrased sometimes. Now let's talk about pyelonephritis, which is another type of kidney infection or UTI. Pyelonephritis is basically an infection of the kidneys, which is more severe than cystitis because remember, cystitis is kind of localized to the bladder itself. Um, Pyelonephritis usually results from ascending infections where bacteria basically travel up from the bladder, up the ureters, and to the kidneys. So you would have systemic symptoms like fever, because in cystitis you wouldn't have fever, but in acute pyelonephritis you would have fever. You'd also have flank pain, like pain on the side over the lower ribs, and that usually suggests kidney involvement. Remember the costovertebral angle physical exam we talked about? If there's tenderness there, that usually indicates a kidney infection, because you're basically tapping and checking if there's tenderness there in that area. And I'll kind of refresh us on that in an upcoming case study that we're going to see and apply it there. There also tends to be symptoms of nausea and vomiting beyond the flank pain and fever. Nausea and vomiting can occur. That reflects more of a systemic response to the infection. You would also have some symptoms of cystitis, like dysuria or frequency. They may also be present, but the addition of systemic signs is more characteristic of the pyelonephritis because that's actually how you're able to differentiate it clinically from cystitis. So the laboratory findings you'd have include from the urinalysis you'd have WBC casts. They're basically diagnostic for kidney involvement because they're formed in the renal tubules. You also have leukocytosis, which basically means elevated WBC count. Sorry, I don't know why I mispronounced that. Leukocytosis. That basically means when there's increased WBC count in blood tests. That also indicates systemic infection cooking inside. Also a positive urine culture, which would confirm which pathogen caused it. Like you want to know which bacteria it was. I showed you in the previous slide here that there are 1, 2, 3, 4, 5, 6 possible pathogens, right? And maybe some others that are not mentioned there. That's the best way to tell. So urine culture, leukocytosis, and also urinalysis. Usually E. coli cause pyelonephritis. Like it's really the most common cause. Like about 90% of cases cause acute pyelonephritis. There could also be Klebsiella species and Enterococcus faecalis, but most of the time it's E. coli. And if this is left untreated, pyelonephritis can lead to a renal abscess, sometimes sepsis, because it's uncontrolled fever, and then also chronic pyelonephritis, we'll see on the next slide. And how to manage it, you'd use antibiotics, usually intravenous antibiotics like ceftriaxone or ciprofloxacin, especially in hospitalized patients, and also some supportive care like fluids, pain management, and also monitoring of the vital signs. And sometimes hospitalization might be required for more, I guess you could say, severe cases or for patients who are unable to tolerate the oral medication. Now let's talk about chronic pyelonephritis. So remember, before we talk about acute pyelonephritis, but if it's left untreated, it can lead to something called chronic pyelonephritis. And this condition is basically referring to interstitial fibrosis or atrophy of the renal tubules. Now, these are vocabulary words I hope that you remember from our Principles of Pathology unit earlier this year in 2024, like January, February, the Principles of Pathology. Remember, atrophy means a lessening of something, like a decline, or I guess you could say degradation of something, in this case of the renal tissue, so atrophy of renal tubules. For example, remember I gave you the example, if you don't use it, you lose it. So let's say a patient is hospitalized for 3 weeks and they're bedbound, they would have an atrophy of their muscles called muscle wasting, because if you don't use your muscles, you'll lose them. And of course, that's why patients who are hospitalized over a couple of weeks might need some extra supportive care in physical therapy after they're discharged. So that's what atrophy is. This can actually, like chronic pyelonephritis can actually result from something called vesicoretral reflux. That basically means backflow of urine from the bladder to the ureters and kidneys. That's often seen in children, or if you have obstruction, like from BPH or kidney stones. And another way this can happen, I can just briefly touch on the pathophysiology of chronic pyelonephritis. There are repeated infections or ongoing obstruction that would lead to cortical scarring and also deformity of the kidney. And in vesico-uretral reflux, the scarring typically occurs at the upper and lower poles of the kidney. And histologically, like on under a microscope, that like if you take a biopsy of the kidney and you slice it into small sections and then you look at it under a microscope, under histology, that's what histologically means. The atrophic tubules, they contain something called eosinophilic proteinaceous material. Basically, there are protein-filled eosinophils that look like thyroid tissue. That's called thyroidization of the kidney, and that shouldn't be happening, right, at all. See, in this picture on the right, you can compare it to a normal kidney. There's scarring, atrophy of the cortex, also some inflammation. Clinically, patients may present with hypertension, mild flank pain, and proteinuria. Proteinuria means there's protein in the urine, like elevated protein. But often, like their symptoms tend to be very vague and they develop slowly over time. And unlike acute pyelonephritis, the fever and the acute systemic symptoms, they're less common unless there is like a superimposed acute infection, because you can have chronic pyelonephritis, and also have a fever, you could have the flu, you could have a cough, you could also just have a UTI as well on top of that. Patients aren't black and white like the textbook. There might be other things going on as well, and you don't want to address them. You would diagnose this through imaging, like an ultrasound or a CT scan that could show scarring of the kidneys or blunted calluses. You could also have urine findings that might include waxy casts that could indicate chronic tubular damage. And you would want to manage this by addressing the underlying cause, like you might have a surgery for the obstruction, you might want to provide antibiotics for the infection, and then you'd also want to control the blood pressure. That's very critical to prevent any further kidney damage as well. So you want to work with cardiology on this. Now that we have some understanding of UTIs and AKIs, I wanted to go over a few case studies, and these are actually more UTI oriented rather than AKI oriented. I just wanted to keep it simple, so these are all UTIs. That might be the best hint I can provide you. So I'll read this off. A previously healthy 24-year-old woman comes to the physician because of a one-day history of nausea and weakness. She is sexually active with two male partners and uses an oral contraceptive. She uses condoms inconsistently, and her last menstrual period was 4 days ago. Her temperature is 101 degrees Fahrenheit, and physical exam shows right costovertebral angle tenderness. Pelvic exam is normal. Which of the following is the most likely cause of this patient's condition? Is it A, ascending bacteria from the endocervix, B, non-infectious inflammation of the bladder, C, ascending bacteria from the bladder, D, decreased urinary pH, or E, a decreased renal calcium absorption? So I'll let you think about that for a little bit. You could pause. But in the meantime, I will just highlight and give you a hint before I provide you with the answer. Again, I'm just giving you like, look, this looks acute because it's just a one-day history of nausea and weakness. There's a fever, so that means there's systemic infection. And there's also a right costovertebral angle tenderness. So it looks like acute pyelonephritis. See here on this is sort of to remind you from our previous session on the physical exam when you want to tell if there is a kidney infection. So this is not cystitis, and this is not chronic pyelonephritis. This sounds more like acute pyelonephritis, because the costovertebral angle tenderness, nausea, and fever, they are classic characteristics of pyelonephritis. Remember, pyelonephritis is an infection of the renal pelvis and the parenchyma that's usually associated with an ascending bacterial infection of the bladder. And that typically presents with flank pain, the costovertebral angle tenderness. Remember, this is the costovertebral angle, and features of cystitis, also fever as well, and like the feature of cystitis, like dysuria and also frequency. So I hope that it should tip you off for the correct answer, which is C. Ascending bacteria from the bladder, typically due to underlying cystitis, is the most likely cause of the patient's pyelonephritis, basically. There are other risk factors that include pregnancy, urinary tract obstruction, from a catheter, or like BPH, benign prostatic hyperplasia. There could also be vesicoureteral reflux. There could also be immunosuppression, also some recurrent urinary tract infections that could cause this. Um, Acute pyelonephritis, but in this case, it was probably you can tell here this is like a young sexually active female who has a fever, and so I felt that this was a good case to show you. It can't be A because I don't want to complicate this. So A would be referring to something called a pelvic inflammatory disease because it's referring to the endocervix. PID, or pelvic inflammatory disease, could explain this patient's fever, nausea, and weakness, but the condition isn't associated with costovertebral angle tenderness. That's sort of how you're able to differentiate and, kind of cross that off the list. Um, and the PID would cause some more abdominal pelvic pain, and possibly like some abnormal vaginal discharge. The answer also can't be B, because this patient doesn't have like chronic interstitial cystitis. Like she doesn't have symptoms of urgency or increased frequency or suprapubic pain, and so that's why like the interstitial cystitis couldn't explain the patient's nausea and weakness, fever, and also like that costovertebral angle tenderness. I would like highlight this 2 times if I could, and underline it because that is really what helped me differentiate and kind of cross off A and B. D, decreased urinary pH. That would promote something called radiolucent uric acid stones. And that usually presents with kidney stones. But there also tends to be something called colicky flank pain. That often radiates into the groin area, and that would make this diagnosis unlikely because there wasn't that radiation of pain into the groin area, and also I didn't teach you that. So that would also make it easier to kind of cross out. And then option E also is incorrect because 2/3 of calcium is basically reabsorbed in the proximal tubule, if you remember from our anatomy physiology session. And a decrease in renal calcium reabsorption can actually cause radio-opaque calcium urinary stones to form. And renal stones would be most common in individuals with excessive supplemental calcium intake or taking certain medications, such as like loop diuretics. And although the patient's nausea, weakness, and the right costovertebral angle tenderness can present with kidney stones, there is an absence again of that colicky flank pain that often radiates into the groin area, and that would make this diagnosis unlikely as well. So now let's move on to the next case study. A 62-year-old female woman with type 2 diabetes mellitus is brought to the emergency room because of a 3-day history of fever and shaking chills. Her temperature is 103 degrees Fahrenheit, and examination of the back shows right costovertebral angle tenderness. Analysis of the urine shows WBCs, WBC casts, and gram-negative rods. Ultrasound examination of the kidneys shows no signs of obstruction, and biopsy of the patient's kidney is most likely to show which of the following: A, polygonal clear cells with lipids and carbohydrates; B, polymorphonuclear leukocytes and tubules; C, widespread granulomatomas, tissue, and foaming macrophages; D, cystic dilation of the renal medulla; or E, tubular eosinophilic casts. So I'll let you think about that. I'll highlight the key information here: the fever, again, the right costovertebral angle tenderness, like we had in the last questions, and also WBC casts, and also gram-negative rods. So again, the findings of the pyuria and also the bacteriuria, they are consistent with acute pyelonephritis. So I didn't teach you this per se, but try to make your best educated guess here. The answer here is letter B, polymorphonuclear leukocytes, or PMNs, in the tubules. They are basically a classic biopsy finding in bacterial infections. The bacteria basically they attach to the tubular epithelium and they trigger an inflammatory response. And then as a result, there's something called pro-inflammatory chemokines. And if you took immunology in undergrad, you probably remember IL or interleukin 8. They are released and the epithelium basically becomes permeable, and that allows PMNs to enter the tubules and also fight the infection. So I'm going to show you here. This is a photo micrograph of a renal tissue biopsy specimen called an H&E stain at very high magnification. And it shows areas of neutrophilic infiltration are visible throughout the renal interstitium. That is like basically on the right hand, right here. It's the hatched green overlay on the right over here. That is especially in tubules shown like there are like on the in the green overlay on the left here that appears dilated. These are dilated tubules. And so these findings together, they suggest acute pyelonephritis. So let's go over why the incorrect answers wouldn't work. A doesn't work because it's basically talking like this is kind of referring to renal cell carcinoma. I didn't go over that with you all yet, but that's kind of what that means. Basically, if there is high like metabolic activity, that's kind of what carbohydrates, when basically when cancer cells are dividing, they need more glucose to divide, more energy to divide, and carbohydrates make up or like they're made of glucose. So that is just sort of referring to that kind of thing. The patient would have like something called constitutional symptoms, which are common for renal cell carcinoma or any really cancer patient. Answer C is incorrect because that would be seen in something called xanthogranulomatomus pyelonephritis. Now, it is a type of pyelonephritis, but it would be seen on ultrasound as an enlarged kidney with hypoechoic masses. And so since we didn't have those buzzers in this question, that wouldn't be it. And so this patient's, oh yeah, and also it said here that the patient imaging was unremarkable. So that would exclude this diagnosis in letter C. D is referring to basically something called autosomal dominant polycystic kidney disease or ADPKD. Patients with autosomal dominant polycystic kidney disease, they usually present at a younger age with recurrent flank or abdominal pain, and they would also have recurrent episodes of UTIs. So I was able to kind of rule this out because it's a 62-year-old person, and also that the ultrasound exam kind of showed nothing really abnormal happening. It was unremarkable. So that would be inconsistent with this diagnosis because, as the name says, polycystic kidney disease, you would see a lot of cysts on the kidney and basically an enlarged kidney. The answer also can be E because these are casts that are common for like remember I talked about chronic pyelonephritis. That's where I mentioned eosinophils. That biopsy finding would resemble thyroid tissue. So in this picture here, it would most likely look more so like thyroid tissue. And as you learn more of different types of different um H&E stains and different microscopic images in histology, you will be very familiar with what a thyroid tissue looks like. But trust me on this one, this is not a thyroid tissue. It looks more like a renal one. And so you would also see a mention of like, hold on here, like it is again, this is a 3-day history of fever. So that also kind of points you towards not a chronic pyelonephritis. Now, this is our last case study for today. A 25-year-old woman comes to the physician because of a 2-day history of burning sensation when urinating and increased urinary frequency. She is concerned about having contracted a sexually transmitted disease, or STD. Physical exam shows suprapubic tenderness, and urinalysis shows a negative nitrite test and positive leukocyte esterases. Urine culture grows organisms that show resistance to novobiocin on susceptibility testing. Which of the following is the most likely causal organism of this patient's symptoms? Is it A, staph epidermis, B, Pseudomonas aeruginosa? I do these questions and I don't pronounce them out loud. I pronounce them in my head. C, Klebsiella pneumoniae, or D, Staphylococcus saprophyticus. So just from the get-go, from what I taught you all, I did not mention the first two microorganisms at all, right? So again, I did highlight the resistance to novobiocin here and a negative nitrate test, but basically this is a young, sexually active woman who presents with features of an uncomplicated urinary tract infection. So she also had a negative urinary nitrate test, and that indicates an infection with and that indicates basically a microorganism or a bacteria with a pathogen that doesn't produce nitrate reductase. And the one that doesn't do that would be D, or Staphylococcus saprophyticus. It can be A because that's a gram-positive coagulase negative organism. It can be B because that is a gram-negative rod that can occasionally cause UTIs, but the patient's urinalysis was negative for nitrate, which means that this organism can't convert urinary nitrate to nitrate, and that makes that infection with the P. aeruginosa much more unlikely because this bacterium expresses nitrate reductase. So I guess you do need to know like which ones produce and which ones don't produce, but that's kind of what makes it fun. C, it can be Klebsiella because that's also a gram-negative rod that can occasionally cause urinary tract infections, but this patient's urinalysis was negative for nitrate, and that indicates again like this one make basically this one also does do the nitrate thing, the conversion of nitrate to nitrite. And so D is correct because Staphylococcus saprophyticus is a gram-positive, coagulase negative coccus that's resistant to novobiosin, and it's consistent with the organism found in the patient's urine culture because that resistance kind of used to differentiate it from other coagulase negative staphylococci. And it's also the second most common cause of urinary tract infections after E. coli in young sexually active women as well. So in case you didn't remember really the details, you can also use like test taking skills. That's kind of how I got this answer right. I didn't really remember which ones do or do not convert nitrate to nitrite or nitrate to nitrate. I just remembered basically which one is the most common out of this list, and that tends to be right most of the time. So again, this was the second most common cause of UTIs in the young sexually active women, and so that is kind of how I came to this conclusion. So I hope that was all helpful for Nephrology Month. We will be taking a break next week, and we'll actually be starting off our pulmonary month in November. We might also be spotlighting a physician who will talk about her journey and career in academic medicine and pulmonary critical care. So be tuned for that in the month of November. And I hope to see you all in upcoming sessions. And as always, the link to the TeleShadowing quiz is now live. Again, we also have the previous quizzes all open from our previous 158 sessions. I believe this is our 159th session. So if you have any questions, feel free to email us at learn@teleshadowing.com, and I hope to see you at upcoming sessions. Take care, everyone, and look